Welcome everyone. For those who don't know me, I'm Ed Holloway and I'm the Chief Executive of the Macular Society, and it's my pleasure to be hosting the webinar this evening. And it's a really exciting one. I'm delighted to say we're joined by Professor Andrew Lotery, who's an ophthalmologist specialising in medical retinal conditions and inherited retinal diseases. He leads the medical retina team at the University Hospital Southampton and also serves as the Chair of Ophthalmology at the University of Southampton. He specialises in looking after patients with inherited retinal diseases, diabetic retinopathy, and age-related macular degeneration. His research focuses on understanding the causes of eye disease and developing new treatments through clinical trials, and he leads a team exploring the genetics of eye diseases, exploring therapies such as stem cells and retinal transplants. Throughout his career, he has received numerous accolades and received recognition in the Times' list of Britain's top doctors. He has published approximately 400 research papers and has been ranked amongst the top experts worldwide in macular and retinal disease. He's also the new chair of the Macular Society's Research Committee, which is essential in driving forward research agenda in our mission to beat macular disease. So there really isn't anyone more qualified to be joining us today to talk about new treatments for macular disease. And he joins us this evening to discuss Lytenava, apologies, I may have mispronounced that, which is the first licensed version of Avastin for wet age-related macular degeneration. And the treatment was approved by the National Institute for Health and Care Excellence, otherwise known as NICE, for use in the NHS at the end of last year. So welcome, Andrew. Thank you so much for being here tonight, and really looking forward to hearing what you have to say about this new treatment. And just a reminder for everyone, if you have questions as we go along, please share them in the chat, and then we'll try and go through as many of them as we can once Andrew's finished talking about this new treatment. Thank you.
Thank you, Ed. Thank you for that kind introduction. And it's always great to be working with the Macular Society. So I'm just going to share my screen with some slides. These are really for an aid memoir for me, so I don't expect you to digest everything on the slides, but I'll try to summarize them. And so really I'm going to start just with just my experience of bevacizumab, which is the generic name for a drug some of you may know as Avastin, and the long road we have been on to try to get bevacizumab available on the NHS. So for many years we have used an unlicensed form of bevacizumab because there wasn't a licensed form available in Southampton to treat patients with various eye diseases. So as many of you know, NICE has a regulation of the level of vision that patients can be treated with drugs for wet macular degeneration. So if you're lucky enough to present very early with a vision better than 6/12 on a vision chart, or if you've presented when your vision has considerably reduced, so you're just about reading the top letter in the vision chart at 6/96, you're not eligible for licensed drugs, what are called anti-VEGF drugs. And so you would not be able to get treatment according to government guidance. So patients who fall outside those levels of visual acuity, we've been using Avastin or bevacizumab for decades, actually, to treat those patients. We also treat patients with new blood vessels in the back of the eye for other causes other than age-related macular degeneration, and we've treat patients with inherited eye diseases such as Sorsby's disease, people with inflammatory eye diseases like a condition called punctate inner choroidopathy or PIC, and for which there is no licensed drug available. Also, patients who have developed unhealthy blood vessels raising their eye pressure, a condition called rubeotic glaucoma, bevacizumab is a very effective treatment to treat that. Also, it's pretty much standard in patients with diabetic eye disease who have developed a bleed in the back of their eye. It's very helpful during surgery to give bevacizumab to help stop bleeding during surgery for removing bleeding in the back of the diabetic patient's eyes. And just to point out, because it was considerably cheaper than licensed drugs, even using it for these relatively small number of indications, in 2019 we used 540 injections of this off-label bevacizumab, and compared to the licensed drugs for macular degeneration, we saved just under £250,000, and that was just in 1 year. So it was very cost-effective treatment. Elsewhere in the UK, paradoxically, perhaps, it's often used to treat wet age-related macular degeneration in private practice, because when patients have to self-pay, it's considerably cheaper than the licensed drugs. It's used first line in some NHS hospitals, such as in Brighton. And on the island of Guernsey, it is effectively the only drug allowed by the island of Guernsey to treat their wet macular degeneration patients. And Miss Susie Dorey, who's a consultant in Guernsey, shared her results with me of how her patients did, and she plotted this graph compared to the results from the clinical trials of the licensed drugs, and the blue dotted line is the results from her center, and basically she was getting the same results in terms of vision improvement as patients in clinical trials who've been treated with another drug called Lucentis, which is very impressive, because the patients in clinical trials it's a much more restricted group of patients, and the best patients you would think would respond. So she was getting the same results with bevacizumab as with these licensed drugs at a fraction of the cost it would have been cost to treat with the licensed treatment. So I first reported using off-label bevacizumab and the benefits of it back in 2006, and this is before we had licensed drugs available. So longer ago than I care to remember, but we reported our results from Southampton and showed that we were getting significant visual gain by treating patients with bevacizumab for wet macular degeneration. And then I was one of the leads for a large multi-center study of bevacizumab versus a licensed drug called Lucentis or ranibizumab, which was run around approximately 20 centers around the UK, and a head-to-head comparison done as a prospective clinical trial. And we published these results in The Lancet in 2013. And essentially, the results were it was the same effectiveness as other drugs used to treat wet macular degeneration. And an American group did a very similar study called the CAP trial, and they found the same results as us. So we had two large-scale clinical trials showing exactly the same thing, that bevacizumab was as effective as the more expensive drug, ranibizumab. And so the World Health Organization then has lists bevacizumab as an essential medicine for macular degeneration. We went on to publish protocols of how to use bevacizumab to treat Sorsby's fundus dystrophy, which, as I say, is an inherited eye condition where you have a problem of leaky blood vessels as well. And really led the way in showing how to treat this condition. So you would think that with all this evidence that bevacizumab should be made available on the NHS, but it was not available, excuse me. And so I sort of campaigned for this to be made available and published several editorials in British Medical Journal, for example. I did this with the presidents, 2 different presidents of the Royal College of Ophthalmologists. And one of the reasons it wasn't used in the NHS was because doctors were worried if they used an off-label treatment when a licensed drug was available, that the General Medical Council would find them were not behaving as a General Medical Council expected them to, and they could get struck off. So I organized a meeting with the Royal College of Ophthalmologists, and we got the GMC, the General Medical Council, came out with a statement saying the use of off-label bevacizumab would not cause us any concerns. So they said it's okay to use it as an ophthalmologist, which was helpful. And then NICE, which regulates for what drugs can be used, also said that given the guidelines, committee view that there's equivalent clinical effectiveness and safety of different anti-VEGF agents, comparable regimens will be cost effective. And they mentioned bevacizumab. So they were supportive as well of it being used because it would be more cost effective. So a group of healthcare commissioners in 2017 decided to make this their policy to use bevacizumab to treat their patients. And they said for this northeast region of England, the policy could save the region's NHS up to £13.5 million a year over the next 15 years. That could pay for an extra 270 nurses or 266 heart transplants. And if we don't use it, we'll have to ration care elsewhere. However, several drug companies challenged this decision, and they essentially took the NHS to a judicial review, challenging the use of this drug because it wasn't licensed specifically for use in age-related macular degeneration. And so I was the expert witness for the NHS effectively in this judicial review. And the judge said the drug company's argument was an absurd proposition. It would give unbounded power to the pharmaceutical companies to decide which medicines to make available for which purposes. And that would be seriously detrimental to the wider public interest in maintaining a cost-effective public health care system. And because of that judicial review, another organization, the MHRA, which also decides on the licensing of drugs, changed its position and said it wasn't an unlicensed medicine, it was an off-label medicine. And that subtle difference allowed clinicians the freedom to choose to use bevacizumab without any legal complications. However, it's still not used widely in the NHS because of these various concerns of it being off-label, it has to be made in a compound pharmacy, not specifically made by a company for that, the indication of treatment in the eye. So now we have a licensed form of bevacizumab available, bevacizumab gamma, or Lytenava, as it's called. And so this removes a lot of the anxieties and should make it more widely available in the NHS. And so this Lytenava or bevacizumab gamma is now available and indicated for all the same reasons as the other drugs that are available in the NHS for treating macular degeneration. And the NICE recommends using the least expensive option to treat people, which includes Lytenava. And they pointed out in the evidence from NICE that evidence from clinical trials show that more people having bevacizumab gamma or Lytenava gain at least 15 letters in best corrected visual acuity compared to ranibizumab. So, so the Lytenava program did a clinical trial comparing it to ranibizumab. They showed that 41.7% of patients treated with Lytenava or bevacizumab gamma gained over 15 letters. That's 3 lines of vision after 11 months of treatment. And the mean improvement in vision after 11 months of treatment was 11 letters. That's more than 2 lines vision gained in patients with wet macular degeneration. So in summary, we now have a licensed version of bevacizumab called Lytenava. This removes the anxiety that some clinicians still have of using an off-label version of bevacizumab. It's been shown to be effective in clinical trials. It is approved by the government regulatory agency, NICE. And so it offers an additional option for clinicians to use in treating wet macular degeneration. And if it's cheaper than other drugs, it of course frees up resources for to develop macular degeneration services. If drug costs go down, you have more budget to hire, for example, more nurses or doctors to help treat patients. So that's really a rapid fire through about 20 years of work on this area. And I hope that was interesting, and happy to answer any questions. And I'll just stop.
Thank you very much, Andrew. Thanks for summarising, as you say, an awful lot of research and progress in a really short time. So thank you. We've had a few questions come in, and I'll go through some of the ones we've had already, but I'm sure people will ask questions as we talk. So first question, someone has been treated for wet AMD in their right eye for over 4 years. They're increasingly experienced distortion and blurring of near vision. They've had several hemorrhages and need injections every 4 to 6 weeks because of fluid. They would feel more secure if they could have injections regularly every 4 weeks. Would having the treatment every 4 weeks delay the loss of near vision?
So what we try to do is extend the interval as far as possible, and not have people on 4 weekly injections if they're doing well. Now, if a patient is continuing to have fluid at a 4 to 6 week interval, and often what clinicians would consider is switching to another drug, and they have slightly different mechanisms of action. So in Southampton, I think we would probably think about, if they haven't been switched to another drug, think about switching. You would stay at that 4 week interval until you're inactive, but obviously there is a trade-off. There's a risk of damage to the eye, of infection in the eye every time you have an injection. And so if you can lengthen that interval to 8 weeks or 12 weeks or 16 weeks, that is desirable for everybody. But it depends on the response. But yeah, so I think you just have to look at that. I think that it is true that the biggest cause of vision loss is undertreatment, and that's been shown multiple times. So you do have to treat at the appropriate interval. But if someone is not doing, we would expect patients not to have to rely on being on 4 weekly intervals. But if they're repeatedly relapsing, as this sounds like it, I would think about changing drug.
Okay, thank you. We've had 2 related questions. The first is, how does it compare with Eylea 8 milligrams, please? And then, is the new drug less likely to cause stroke than Eylea?
So it should have the same clinical effectiveness based on indirect comparisons in terms of visual acuity outcomes. What we don't know is how long an interval you can extend between injections with Lytenava versus Eylea 8 milligrams. So the clinical trials for Eylea 8 milligrams were designed to test how far you could extend patients, and they showed they could maintain patients out to 16, the majority of patients out to 16 or even 20 weeks after 2 years of treatment. And we don't have the same length of follow-up with Lytenava yet. In terms of visual acuity outcomes, I think as long as you're being treated anytime you're active, it's likely that the outcome will, in terms of visual acuity, will be the same, but we don't know whether the interval between treatment can be as long as yet with Lytenava. Sorry, was another bit of that question? Or was that...
Is the new drug less likely to cause stroke?
Oh, yeah. So stroke, it's a really interesting question. So because you're switching off blood vessels, blood vessel growth, people are concerned about the risk of stroke, or giving the drugs in patients who've had a recent stroke. In clinical, so this is a theoretical risk. In clinical trials, there's been no increased risk of stroke in patients receiving these drugs. So a very tiny amount of any of these drugs gets out of the eye into the systemic circulation. You know, it is a very tiny amount of drug is injected into the eye, and even a smaller amount leaks out into your bloodstream and gets to your brain. So the risk, there's been no evidence of increased risk of stroke in clinical trials of patients treated with this. That said, when patients have had a stroke or had a TIA recently, because we don't really know whether it would be damaging, we tend to maybe defer for a month or 3 months, but you have to end the risk, weigh up the risk to the eye of not treating if they need treatment. So I'm fairly, you know, if someone had a stroke last week, I'd probably not give a drug. I'd probably defer it until it's a month after their injection, after their stroke. But I have to say there's no actual evidence that these drugs cause stroke, any of them. So, and that's a common misconception. And people are often delay treatment, I would say, sometimes unnecessarily, and then get worse vision as a result of that.
Thank you. So the questions are now flying in thick and fast, and we'll try and sort of group them where they're asking about similar things. And just a reminder for people watching, we have people dialing in from all over the world. So some people are obviously, you know, different healthcare systems. So one question is, do you not use Vabysmo in the UK? And apologies.
We do use Vabysmo, yes.
And then the related question was, they have Vabysmo injection every 3 months. If Lytenava was suggested, would you need to have the monthly loading doses to start with?
Yes, so we do a loading dose for all drugs of 3 injections in the UK anyway. At least 3 injections at a 4-weekly interval, and then try to extend the interval between injections after that. And there's different, some people extend by 4 weeks, some people by 2 weeks. So you might go to 6 weeks or 8 weeks after an initial dose of three injections at 4-weekly. As I say, there are a small number of studies using bevacizumab in a treat and extend protocol, but the more modern, more recent studies for Vabysmo or Eylea, high dose or 8 milligrams have really tested this paradigm more than previous studies in terms of getting people out to 16 weeks or 20 weeks between injections. And we don't yet have that data for Lytenava. So I can't say, you know, it's so new, we can't say how big an interval we can have between injections as yet.
Okay. I think this probably links into that. So does it require more frequent administration, or is the dosage the same?
So as I say, we don't have the evidence that you can extend intervals as much as for the other drugs. I think clinicians will probably try this and try extending and then collect real world data, but we don't have a randomized trial as yet to give us that information for Lytenava. So it's a good point, and I think it's something that needs more research.
Okay, thank you. I've only had Ongavia and I'm a 10-week cycle. Will Lytenava be more beneficial?
So 10 weeks isn't bad in terms of a treatment interval. Possibly. As I say, we sometimes we find out we can extend a bit longer if we switch from one drug to another, but it is quite individual specific, and it's hard to predict who will benefit versus who won't. So Ongavia similarly it's a biosimilar of ranibizumab, or Lucentis. So Lucentis was the initial licensed drug, and now there is a cheaper biosimilar form of it, which is also licensed. And so so some people are using Ongavia instead of Lucentis now.
Okay. So I'm just checking the wording if this is correct. Is this a drug that will be used when other drugs are working? I think they might mean when other drugs are not working. I've been through the 3 drugs on offer over the last 2 years and needed 4 weekly injections, but have had continued leakage of vessels.
Yeah. So, but absolutely, it gives us another tool in our kit bag. They all there are, while the visual acuity outcomes are the same, they do give slightly different responses in terms of the amount of fluid that dries up in the retina, and so sometimes it is helpful to switch from one treatment to another. So if you haven't responded to other drugs, it might be an option to think about switching to Lytenava to see if it gives a better response.
Okay. Have you been able to discharge any patients when treated with Avastin? Does it depend if they were drug naive prior to treatment with Avastin?
We have managed to discharge patients with Avastin. Does it depend? So you do get the best, I would say you get the best response to any treatment if you see the patients earlier in their disease. The blood vessels are more responsive. So patients who are switched from one drug to another tend to be the more resistant patients and more difficult to treat with more mature blood vessels. I'd say treatment naive would be give you the better chance of being able to stop treatment and ultimately discharging the patient.
Thank you. I've had 1 injection of Vabysmo in the last 7 months. I'm concerned this treatment is too far apart.
Yeah, I mean, as I said, it really depends on how your eye looks, and if it's again, it's about risks and benefits, and there's a small risk of infection, damage to the eye every time you have an injection. If your eye is completely stable and no sign of reactivation, it would be reasonable not to continue treatment. Providing that you're being observed, and if there was any sign of reactivation, then getting treatment quickly. So we would, in Southampton, would treat people out to they're having injections every 4 months. If they have 3 cycles of treatment with no signs of activity at 4 months, then we would stop treatment and observe them for a year to make sure they don't reactivate. And if they're stable for another year, then we would discharge. So yeah, we don't want to treat people for the rest of their life if we can avoid it.
Yeah, absolutely. I've had Lucentis injections for 12 years, and I luckily kept my eyesight stable up till now. I'd be concerned if the injections were to change.
I mean, if you're doing well in one drug, I don't think there's a great need to change. There is a alternative form of, there are biosimilar forms of Lucentis, which are cheaper. So some units are using them, but they should be equally effective as Lucentis. So Ongavia is one example, which you mentioned there. There are other biosimilar forms of Lucentis, or ranibizumab as its generic name is, but they should all work in exactly the same way.
Okay, thank you. Is this treatment being used for patients with RVO?
So it's just licensed for age-related macular degeneration at the moment. So it would just be for that at the moment. That's what its authorization is.
Is the new treatment available in London, as delays in treatment are put down to cost?
So Lytenava should be available in London, yes, because it should be a cost-effective option. Yeah. I understood it correct, yeah. Yeah. And there are. I mean, it's fair to say that different health commissioners in different parts of the country have different views on what drugs should be used for treating wet AMD, and particularly in London, sometimes they can be quite restrictive in what clinicians are allowed to use. But I would imagine they'd be quite keen to use for us to use Lytenava in London, because it should be a very competitive in cost.
Yeah. Does the Royal College of Ophthalmologists have any preference in the management of AMD and types of injections?
It would just say, so there are guidelines, or there have been guidelines published by the Royal College of Ophthalmologists, which have been very helpful actually in developing services. So they don't have a specified drug. They would just any drug that's been approved by NICE. They do stipulate that the standard is you should, from the point of referral to an eye department, you should have treatment within 2 weeks, which is a challenging standard to meet, but it does focus people's minds and trying to develop the resources to meet that. And they're absolutely right. Again, because the best effect comes by early treatment.
Okay. I have PIC, and you might want to explain what PIC is for those who don't know. And then currently stable and only receive Lucentis injections with a flare-up. Avastin and Eylea just didn't work as well. Will this work the same for ad hoc injections as required?
So PIC's an inflammatory eye condition. It stands for punctate inner choroidopathy. So you'd see lots of little punctate, little dots in the back of the eye. And occasionally you can get unhealthy blood vessels growing, which can cause scars in the back of the eye, just like age-related macular degeneration. But it typically affects particularly women in sort of their 30s or 40s, so younger age group. So we've used Avastin effectively in PIC. So I would be happy to use Lytenava and for PIC. But if this particular patient has had a good response to Lucentis, there's no, they could just stick with that. I should say there can be a bit variable from patient to patient. Some people seem to do better in one drug versus another.
Thank you. If you have a stable brain aneurysm, is there any evidence that either 8 milligrams Eylea or Lytenava injections could be an issue?
Just trying to think if there's any. I don't think there's any evidence it could be an issue. We do have some conditions that cause aneurysms inside the eye and the brain, and I think I've had treatment with these sorts of drugs and there hasn't been any problems with the brain. Again, you're injecting 0.05 milliliters of fluid into the eye. 1,000th of a milliliter of the drug gets into the bloodstream. It is very dilute by the time it gets to the brain, so it's unlikely to have any significant effect. So I don't think it's a bit like strokes. I don't think it's an issue.
Is the 8 milligram Eylea going to be more painful?
So we've been using it. It doesn't seem to be. It's a slightly bigger volume, but in clinical trials, there weren't any increased side effects from the injection compared to the dose of other drugs, which is 0.05 milliliters versus this, it's 0.07. So particularly eye pressure did not go up any more higher in the 8 milligram dosage versus let's say the 2 milligram dosage of Eylea. So surprisingly not. I would say it can be given with the same type of needle, so it doesn't require a bigger needle. I don't think you'd notice any difference as a patient.
That's good news. Someone is 78 and have wet AMD. They've had 3 injections of Eylea. How can they get it changed to this new drug that you are discussing? And they're in Grimsbury, Northeast Lincolnshire.
I think just talk to your clinician and just get their opinion whether it'd be helpful or not. So yeah, talk to the medical team that are looking after you about your different options.
Is Ongavia an old drug? Are there better drugs with better outcomes and they have 2 milligrams?
Sorry, what was the last bit? Better outcomes than they have?
They have 2 milligrams of Ongavia.
So Ongavia is the biosimilar form of Lucentis. So Lucentis was the first drug to really show an improvement in vision with treatment for wet AMD. So it really transformed the landscape of treatment, where prior to that there was no effective treatment really. So it is an old drug. I guess nothing has beaten Lucentis, and by association, because it's the biosimilar form Ongavia, nothing has beaten it in terms of visual acuity outcomes in 20 years of trying. So again, it hasn't really been tested in these extended intervals in the way that drugs like Vabysmo or Eylea 8 milligrams have been tested recently. So some doctors prefer using Vabysmo or Eylea 8 milligrams because we have clinical trial data giving us confidence about the drug can be, the interval between treatment can be extended, and we don't have that for Eylea or Lucentis. So it is an old drug, but it's been proven to be a very effective drug, and so it just doesn't have the evidence for, in clinical trials of a 16-week extension between treatment. But in terms of the number of letters gained with regular treatment with it, it's as good as any other treatment.
That's good to hear. Please, could you clarify how long the assessment interview, I think this was the same question a person asked earlier, how long the assessment intervals would be before discharging at the end of the year? Would it be every 4 months, the same as the treatment had been extended to?
So when we stop, I mean, it varies. I would say there's not an absolute consensus on this, so it varies from unit to unit. In Southampton, we would review you every couple of months initially once we'd stop treatment. So we might do that 5 times or 6 times, and then discharge you after that. So, but it's every 2 to 3 months, I would say, for a year following the decision to stop treatment. But we would only do that if you've had 3 injections at a 4-month interval with no signs of activity in any of those, after any of those injections. So it's sort of a cautious stopping, but some doctors would continue treating or try to extend to 20 weeks now, 5 months. So there are some new drugs in clinical trials that purport to only need treatment every 6 months, and so it's changing. The methods or the care pathways are changing all the time as new evidence comes about.
Yeah. This might be a controversial question. I don't know if you'll answer this, but which location in the UK is considered to be a centre of excellence? And they've said other than Southampton.
Well, thank you for saying Southampton. I think there are there's lots of good centres. Bristol has got a very good eye department. Muirfields in London, other London centres. Newcastle, Liverpool, Manchester, all have excellent track records. There's other places as well where we have, I would say, anywhere that there's a research active team, I think that's the sort of the common denominator. It is proved that, I mean, there is data that clinical outcomes are better in hospitals that are research active. So it might surprise you, Bradford and Hull also have very good track records, and they are very involved in clinical trials research and macular degeneration as well. So I think anywhere that is research active and has interested clinicians tends to get the best outcomes. And that, as I say, that's been shown in clinical, in the hospitals with the most research funding have the lowest mortality rates, for example, which I think is really interesting. So, if you're sick, I would say go to a hospital that is research active, and so often those are university hospitals, university teaching hospitals.
Yeah, fascinating. I spent a long time at the MS Society, and that would have been my subjective opinion. But it's interesting to hear that is backed up by evidence and across all conditions. Yeah, good advice then. Thank you. On a different topic, I'm unclear. Is the driver behind the new drug cost? I said cost. Oh, I think cost or improved efficacy when treating wet AMD.
So I think it's what it's demonstrated is really equivalent efficacy to the other drugs. So it so I guess one driver would be that cheaper, yes, that it could be more cost effective, which of course then allows budget to be spent developing services in other ways, and not just all the money going on drug costs. So potentially helping, as I mentioned, hiring more staff. So an AMD service isn't just a drug that you use; it's having all the infrastructure to deliver the treatment, of course, as well.
Yeah, of course. I've been stable at 6/15 in my right eye, with GA in my left at 6/24 for a year without injections. What is your view on intraocular devices to maybe help improve my vision?
So I think that's referring to intraocular telescopes. I don't think the evidence is yet that strong that they're helpful for most people. If you have, as this patient mentioned, a good vision and relatively good vision in one eye, you're going to have perhaps distorted vision if you have a lot of magnification in one eye and not the other, possibly even double vision. And I'm not sure there's much evidence that they're better than electronic magnifiers or even handheld magnifiers. And it's quite technically challenging surgery to put them in. They're big devices often, so there's perhaps a bigger risk of surgical damage. So I personally don't recommend them yet, because I don't think, well, A, they're not available on the NHS, and that's because NICE doesn't think the evidence is strong enough either. And yeah, I just don't think there's enough clinical trial evidence yet that they're that helpful. Essentially what they're doing is magnifying an image onto the peripheral retina, and you can get exactly the same response with a magnifying device, like a handheld magnifier with a light, or an iPad where you've enlarged the text. So I think it's a little bit early yet to recommend them.
All right, we're going to go to a completely different topic now, but we've got a wide range of questions. So where are we up to with retinal transplants or gene/stem cell therapy to circumvent AMD?
So gene therapy, there is several trials of gene therapy to treat wet macular degeneration ongoing at the moment, and preliminary results are encouraging. So the idea here is that you use a viral vector, a virus, to implant a gene that would make a drug like Eylea inside your eye on a continuous basis. And once you've had the operation to have that gene therapy, then that would mean you wouldn't need further injections. So I think that the preliminary results are good. There's ongoing clinical trials, and that's potentially something, particularly for people who can't get off that cycle of 4 weekly injections. The phrase one and you're done is sometimes said about gene therapy. You have one procedure and that's it. You have then that constant supply of whatever drug it is being delivered into your eye all the time. So gene therapy is looking promising for wet macular degeneration. There have been drugs tried for dry macular degeneration, complement inhibitors. so far they haven't been very effective, and that's why they haven't been approved in the UK. Because, however, if we get a more effective drug for dry macular degeneration, using gene therapy to deliver that drug could be a very effective way to, again, to avoid the need to have repeated monthly or 2-monthly injections for the rest of your life. So expertise with gene therapy is increasing in ophthalmology, and I think we will see treatments for AMD, particularly for wet AMD. That's more advanced options in the next few years. Stem cell therapies have so far not been proven to be effective, and I think have been sadly overhyped a little bit. So they have not shown benefit as yet. So the retina is sort of a sandwich of layers of tissue, and you've effectively got 4 layers of tissue that makes the retina that senses light. We can put in a sheet of cells on the base layer, called the retinal pigment epithelium, and that can be done through stem cell technology, but we can't put in the 3 layers above that, and we can't get those layers to connect to the nerve that carries the visual signal to the brain. So it's proved a lot more challenging than people thought to do stem cell therapies for macular degeneration. So I think it's a lot further away than gene therapy. And so for the similar reason, retinal so there are some cameras being tried that hook up like to the brain. Early trials, some of them have got some good results. We'll just have to see how that develops. There's also some trials of making some of the cells in the eye that aren't light sensitive, again with a gene therapy approach, and they're in early studies are looking promising. So that might be something for the future as well. So I think gene therapy for drug delivery is moving forward quite quickly. Gene therapy to make other cells in the retina light sensitive might be something as well. It's a little bit further back. Stem cells, I think, are quite, not in the foreseeable future, I think, effective at the moment.
Really exciting, though, the idea of a treatment that then your own body is making the drug and not having to go through those repeated treatments, really.
Yes. And that's in phase 3 clinical trials. So that's the last stage of clinical trial.
Extraordinary.
Prior to being approved for treatment. So yeah, that's why I say it's quite the next couple of years.
Yeah.
Good treatment.
Brilliant. Yeah. And you may have sort of answered this anyway, but what do you think will be the next big change or development in treating AMD?
Well, so there's several longer durability treatments. So gene therapy, as I mentioned, is coming. There's what's called the port delivery system, where you put a little reservoir of drug in the eye that can be topped up by an injection on just like a normal eye injection. But this reservoir holds the drug, and again might not require a further injection for 6 months. There are some polymer implants that slowly let drug leaks out of the implant, and again, in early studies are showing you don't need to treat people more frequently than every 6 months with an injection. So I think in the next few years, we're going to get treatments that will allow a significant number of people to go 6 months without an injection, or maybe indefinitely through gene therapy.
There's a question about where you can take part in clinical trials, and please do answer it, but I'll also plug, it's been posted in the chat, but on our website, if you go to research and then get involved, there's lots of information about clinical trials and opportunities. But I don't know if there's anything else you'd suggest for people.
Yeah, well, I do suggest to my patients they join the Macular Society, because I do think you're very good at through your news bulletins of letting people know, and sometimes drug companies reach out to the Macular Society asking if you've got any patients who'd be interested in clinical trials. We also need patients to be part of clinical trial investigator groups and for our studies. So increasingly we have patients as part of the investigator group. So if people could volunteer through the Macular Society for that, that would be helpful. So I think probably ask your doctor if they know of any clinical trials that might be helpful or available. So it's always, ask your current doctor. There's also a website called clinicaltrials.org, which where most clinical trials around the world are registered, and you can filter by country and by disease. So talk to your clinician who could advise. They may be doing clinical trials themselves, or they could refer you to a neighboring hospital. And there are these websites as well.
Thank you. I think that's probably a really good note to wrap things up. But thank you so much for such an informative talk, and then just going through all of those questions, really absolutely extraordinary, and showed you definitely lived up to your reputation. So thank you very much, and well done. Just very briefly, so thank you everyone to joining. So next month we'll be joined by Dr. Kezia Latham from Anglia Ruskin University and her PhD student Andrew Miller. They will be joining us to discuss the latest findings in their groundbreaking research projects, which have been comparing the effectiveness of different low vision aids. So really interesting, quite a different topic from what we've had today. So this is a Macular Society funded study which aims to provide clear, impartial evidence on how devices designed to make life easier for people with sight loss can impact quality of life, and whether they offer good value for money. So that sounds like it's going to be absolutely fantastic. That takes place on Tuesday, the 18th of March at the usual time at 7 p.m. So please do join us then. And thank you again so much, Andrew. It's been an absolute pleasure. I think I can see lots of people saying thank you in the chat for all of your answers. So thank you again for all of your time and for sharing your knowledge. And have a lovely evening, everyone. Take care. All the best. Bye.
Thanks. Bye.